Good afternoon, and welcome to the What is an Antibiotic Stewardship Program. My name is Sunera, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-answer session. During the question-answer session, if you have a question, please press star, then 1 on your touch-tone phone. I will now turn the call over to Ms. Jane Rogers. Ms. Rogers, you may begin.
Good afternoon. Welcome to What is an Antibiotic Stewardship Program webinar. My name is Jane Rogers, as she said, and I'm a clinical quality consultant from the Lake Superior Quality Innovation Network, or Lake Superior Twin. Lake Superior Twin represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. This webinar is intended for all nursing homes in Michigan, Minnesota, and Wisconsin who are participating in the National Nursing Home Quality Care Collaborative. This webinar is the third in a 4-part series. These webinars, which include how to implement an antibiotic stewardship program, as well as how to prevent, manage, and track C. difficile infections, are designed to assist your nursing home in improving quality of care and outcomes for residents, as well as meet the reform of requirements for long-term care facilities' infection control requirements. All lines will be muted during this webinar. However, if you have questions during the presentation, please share them in the chat box. There will also be an opportunity to ask questions after the presentation. In the webinars and virtual learning sessions that Lake Superior Twin has offered to nursing homes, we have emphasized the importance of developing the culture in your nursing home to better support quality improvement. As a reminder, the NNHQCC Change Package offers strategies that your team can implement to develop and enhance your quality culture. In this Change Package is a bundle of strategies implemented by high-performing nursing homes to prevent healthcare-acquired infections. Please refer to the link on this slide to access this Change bundle. It describes actions utilized by nursing homes and supported by the literature to help prevent healthcare-acquired infections. During this webinar, we will provide an introduction to antibiotic stewardship programs and methods to track them in your nursing home. Today, we will describe an antibiotic stewardship program and why it is important, define the 7 core elements of antibiotic stewardship for nursing homes, identify steps to implement the core elements in your nursing home, and describe ways to monitor your program's progress. So, what is an antibiotic stewardship? Dr. Namali Stone at the Centers for Disease Control and Prevention defines antibiotic stewardship as a set of commitments and activities designed to optimize the treatment of infections while reducing the adverse events associated with antibiotic use. As you have previously learned from this series of webinars, the misuse and overuse of antibiotics in all care settings should be of great concern to us. Today, however, we will be focusing on nursing homes. Why is antibiotic stewardship important in the nursing home setting? According to the Centers for Disease Control and Prevention, as many as 75% of antibiotics prescribed in nursing homes may be unnecessary or inappropriate. As we have learned in previous webinars, overexposure to antibiotics can lead to severe consequences, including the buildup of antibiotic-resistant organisms and the development of C. difficile infections. Antibiotics can also cause adverse drug events like allergic reactions or antagonistic interactions with other medications. So do we really use that many antibiotics? Yes, we do. Those statistics may be surprising, but yes, the CDC estimates that up to 70% of nursing home residents receive at least 1 course of broad-spectrum antibiotics in a year. Antibiotic stewardship is especially important in long-term care settings. Residents of nursing homes are generally at a higher risk of colonization with bacteria due to the presence of invasive devices, wounds, and conditions that affect the bladder. In older or frail adults, it is often difficult to identify colonization of bacteria from a true illness, and this can lead to the overuse of antibiotics. Actions taken by a facility to improve antibiotic use can assist in reducing adverse events and preventing emergence of antibiotic resistance. This promotes better outcomes for the residents of your facility. To address the rising rates of antibiotic resistance and adverse reactions, in 2016, the Centers for Medicare and Medicaid Services, or CMS, released the Long-Term Care Final Rule. Section 4A3.8 of the rule now mandates that long-term care facilities establish an infection prevention and control program that includes an antibiotic stewardship program. The IPCP program must be based on a facility and resident assessment and conducted and reviewed annually. Nursing homes must have their programs in place by November 28th of this year. The next few slides are going to cover some of the requirements of the IPCP. I will not go through each slide in detail, but highlight some points that will affect your antibiotic stewardship program. The slides will be available for your review if you'd like to come back to them later. The infection prevention and control program must include a system for identification, surveillance, treatment, and control of all infections, which is an important step in building an antibiotic stewardship as well. Nursing home IPCPs must be headed by an infection prevention and control officer, or an IPCO. The IPCO must work with the facility's quality assurance and performance improvement, or QAPI team, to oversee infection control and antibiotic stewardship activities. Policies, procedures, education, and training will be critical to the success of your infection control and antibiotic stewardship program. To ensure a successful program in your facility, the IPCO will need to educate and work with staff, residents, volunteers, contract employees, and families. So at this point, if you are the IPCO for your facility, your stress level may be starting to rise a little bit. But don't panic. There is guidance for building your infection prevention and control program. Today we will review the building blocks available for putting together your antibiotic stewardship program. The CDC's core elements of antibiotic stewardship for nursing homes provide 7 main tenets of a strong antibiotic stewardship program. These 7 elements include leadership commitment, accountability, drug expertise, action, tracking, reporting, and education. We will review each of these in more detail and provide examples of ways they can be implemented in your facility. The first core element, leadership commitment, is essential to an achievable and sustainable antibiotic stewardship program. It requires that leaders demonstrate support and commitment to safe and appropriate antibiotic use in the facility. This can be done through a variety of methods, such as writing statements in support of the program, statements that are shared not only with your staff, but also with your residents and the family members, including antibiotic stewardship duties and job descriptions of your employees, and building a culture that supports and promotes communication between staff and physicians and expectations of appropriate antibiotic use. Next, we have accountability. Once you've established that your team is committed, it's time to discuss accountability. Accountability requires that a clinical leader is identified to promote and oversee antibiotic use in the facility. This can be done by one or several leaders, including the medical director, director of nursing, or pharmacist. People in these roles can set expectations for antibiotic use through policies and communication and can review prescriptions to ensure that they're appropriate. The results of these reviews should then be shared with your staff and prescribers to promote accountability to antibiotic stewardship. The next core element is drug expertise. Know who you can call for assistance. This core element requires that you have access to individuals with experience or training in antibiotic stewardship. This can be achieved by working with a consultant pharmacist or by developing contacts with hospitals in your network that already have an established antibiotic stewardship program. You can also work with infectious disease consultants in your community to ensure appropriate treatment of infectious diseases in your facility. Action. The core element of action is achieved by implementing at least one policy or practice to improve antibiotic use. This can be done in several ways, including some that have already been mentioned. As a facility, establish a policy that requires a review by an expert for any new antibiotic prescriptions, or have the pharmacy confirm all prescriptions. Another policy that has been successful in many hospitals is requiring an antibiotic timeout. This policy implements a review of the necessity of antibiotic treatment after 48 hours. If the treatment is still required, the timeout provides a chance to review the best drug for the job and then switch to a more targeted antibiotic if possible. Tracking. Tracking antibiotic use is the best way to determine the success of a stewardship program and what areas can be improved. This core element requires monitoring one process measure and one outcome measure related to antibiotic use in your facility. Tracking measures of antibiotics can include why antibiotics are prescribed, how many are prescribed, and the outcomes of the prescriptions that were given. Specific ways to track these measures will be described later in the presentation. Reporting. The measures that you choose to track can provide helpful feedback to prescribers, nurses, and staff. Data collected can be shared with your coffee committee and unit staff. Sharing the data reports and results with your staff allows them to be aware of antibiotic use in the facility and promotes accountable and appropriate use. Additionally, peer-to-peer comparisons for providers have been proven to reduce unnecessary antibiotic use. If available, a pharmacy list of patients on antibiotics can provide the number of patients on antibiotics from each prescriber. This can be compared to other prescribers to provide some peer pressure for prescribers that overuse antibiotics. Education. The final core element is education. Education includes providing resources to all parties, including staff, residents, and families about antibiotic use and resistance. This can include information on the goal of antibiotic stewardship and each group's role in preventing resistance. Engaging residents and family members will encourage providers to comply with policies in the facility. Use a variety of mechanisms for disseminating this information. So now that you've got your program set up, how do you assess it? To do a quick assessment of your facility's antibiotic stewardship program, you can complete the core elements facility checklist found at the link on this slide. The checklist provides examples for how to implement each element and gives you a good, solid base to start from. Checklist findings. When you've completed that checklist, discuss the findings with your coffee team. What do you already do well to promote antibiotic stewardship? What might be the hardest piece to implement and why? Where are the opportunities for improvement and implementation? Questions like these can guide your discussion and create a framework for next steps that can be taken in your facility. Following your review, decide what your action items are going to be. The discussion with your coffee team can be followed up with picking one or two elements not currently in place to take action on. Over time, as improvements are implemented, your efforts can be expanded to continue improving antibiotic use. The most critical thing you can do is commit now to ensure antibiotic stewardship policies and practices are in place to protect your residents and to improve clinical care in your nursing homes. Next steps. So once a commitment to protecting your residents is established, your facility can work in a stepwise fashion to expand stewardship. Any action taken to improve antibiotic use will reduce adverse events, prevent resistance, and lead to better outcomes for your residents. Monitoring your program. An antibiotic stewardship program must be monitored to ensure success and compliance with the long-term care final rule. There are a variety of methods to track your facility's progress, which my colleague Anne will now tell you about.
Yeah, thanks, Jane. So there are a variety of ways to measure antibiotic stewardship, and they fall into three major categories. Process measures are used to track how and why antibiotics are prescribed. Antibiotic use measures are used to track how often and how many antibiotics are prescribed. And antibiotic outcome measures track adverse events and costs related to antibiotic use. I'll describe methods, uses, and limitations for each measure to help you choose which could work to monitor your antibiotic stewardship program. So process measures are a great evaluation of specific areas of your stewardship program. There are three measures that are mainly used. The first is a measurement of the completeness of clinical assessment documentation at the time of the antibiotic prescription. This means that the documentation of the resident's status, exam, or lab findings, basically whether the reason for an antibiotic prescription is written down when the antibiotic is prescribed. This can prevent a lot of overuse of antibiotics by reducing the number of just-in-case antibiotics. It also helps prescribe the most narrow-spectrum antibiotic for the infection rather than one that can have larger than intended effects. To gather the data for this measure, you can perform audits of completeness of standard protocols for infection assessment if your facility has those standard protocols. The second process measure is very similar. It's a measurement of the completeness of antibiotic prescribing documentation. This can also be done through audits of documentation. The documentation provides the reasoning for prescription of an antibiotic, whether it was prescribed in the long-term care facility or not. An antibiotic prescription from any prescriber should include the dose, duration of therapy, and clinical indication for the prescription. The final process measure is to determine the appropriateness of the chosen antibiotic. It is a measurement of whether the antibiotic selection is consistent with recommended agents for the infection. This can be done with the experts that Jane talked about from the prior elements. They will determine whether a chosen antibiotic is consistent with treatment guidelines or whether the antibiotic can be changed to optimize effectiveness. Monitoring this measure does require facility treatment guidelines for the infections. So while process measures can be very useful for identifying specific overprescribing patterns related to conditions, symptoms, or individual antibiotics, often the audits they require to track are extremely time-intensive. So measures of antibiotic use give a more general look at antibiotics in your facility. So the first measure of antibiotic use, a point prevalence measurement, can be used to track the proportion of residents that are on an antibiotic at any one time. It's an easier way to gather overall antibiotic use data. In addition to providing a snapshot of the burden of antibiotic use in a facility, point prevalence surveys can capture specific information about the residents receiving antibiotics and indications for antibiotic therapy. Unlike other antibiotic use measures, which focus only on the prescriptions initiated in the nursing home, prevalence surveys, like point prevalence, could also include data on residents admitted to the facility already receiving an antibiotic, and that allows tracking of the total burden of individuals at risk for complications from antibiotic use, like C. difficile and resistant infections, as you learned. Point prevalence data, once you've gathered it, can be broken up into several different categories stratified by specific resident characteristics. So, for example, you could look at antibiotic use among short-stay versus long-stay residents, or antibiotic use for new admissions specifically. However, because prevalence surveys are often conducted only for a brief window of time, this data may not necessarily portray the magnitude of antibiotic use in your facility. A single-day prevalence survey, for example, may show 5 to 10% of residents are receiving an antibiotic. But studies that follow a group of residents over a long period of time, like a year, can show that as many as 50 to 75% of residents have received one or more courses of antibiotics. The rate of antibiotic starts can be a way for you to gather that more long-term data that point prevalence can't. Antibiotic starts measures the number of antibiotic prescriptions written after a resident is admitted to the facility. Many nursing home infection prevention and control programs already track new antibiotic starts occurring in the facility as part of their infection surveillance activity. Comparing the number of starts before implementation of an antibiotic stewardship intervention to the number of starts after an intervention can be an indicator of the success and uptake of the antibiotic stewardship intervention. So to calculate antibiotic starts, it's often calculated as starts per resident days. Resident days can be quickly calculated by adding up the daily census for each day you're measuring. So for example, the daily census of a month, add that for each day over the month. Antibiotic starts can be measured overall or by condition or provider. This can be, if you use by provider, it can be used in that peer-to-peer comparison that was mentioned earlier. But if you do the provider-specific rates, you must take into account the differences in the total number of residents cared for by each provider. Overall, tracking and reporting antibiotic start data could assess the impact of antibiotic stewardship activities designed to educate and guide providers on situations when antibiotics are not appropriate. Interventions focused on shortening the number of days of therapy, though, may not demonstrate significant changes in antibiotic starts. So another way to track antibiotic use is by measuring antibiotic days of therapy, or DOT. Tracking the days of therapy can require more effort than tracking starts, but it may give more information on changes in antibiotic use over time. A term you may have heard is the antibiotic utilization ratio, or AUR. That is the ratio of days of therapy to resident days. And what it does is provides an overall rate of antibiotic burden in the facility. Days of therapy is measured as 1 day for each day a prescription is administered. So, for example, if a resident is prescribed a 7-day course of amoxicillin, that course equals 7 antibiotic days. However, if a resident is prescribed a 7-day course of ceftriaxone plus azithromycin, then that course equals 14 days of therapy, 2 antibiotics per each 7 days. So you can use this information to gather an overall understanding of the amount of antibiotics that are being used in your facility over a specific time frame. The examples on the slide are given for the time frame of monthly days of therapy and AUR. The final category of measurement you can use in your antibiotic stewardship program is antibiotic outcome measures. Tracking the outcomes of antibiotic overuse is a great way to determine the effect that antibiotics are having in your facility and can provide some concrete data that will encourage buy-in to antibiotic stewardship. So as you learned in the last webinar, C. difficile and antibiotic resistance are directly related to antibiotic use. Many of you are participating in our C. difficile tracking initiative, so you are ahead of the game on this measure. The data you collect each month on C. difficile cases and resident dates can be a part of measuring your antibiotic stewardship program. So if you'd like to join that initiative and get personal assistance in tracking your C. difficile cases as an antibiotic outcome measure, please contact the state representative listed at the end of these slides and we'll help you out. In addition to C. diff, though, antibiotic outcome measures also include adverse drug events and costs of antibiotics. In 2014, the Office of the Inspector General reported that nearly 40% of harms in skilled nursing facilities were attributable to antibiotics. Tracking these results is the first step to reducing that harm. On the other hand, very few, if any, studies at all on antibiotic use in nursing homes calculate the financial costs. In acute care settings, though, antibiotic stewardship has been shown to reduce hospital pharmacy costs in addition to proving antibiotic use. So this can help justify the time and effort of an antibiotic stewardship program and encourage leadership support from the financial perspective. So when you have your data all gathered, look for the answers to these questions to understand the antibiotic use in your facility. The answers to who is prescribing, what is most frequently prescribed, where are the units where antibiotics are being used most, when antibiotics are most likely to be prescribed, and why are they being used, can help you to have more meaningful conversations with providers and help develop guidelines with their input. With these questions, seek to understand why antibiotics are being used, because the reasons may be different than you expect. The pharmacy also can often provide reports to help you answer these questions. So your data may expose some areas that need to be improved in antibiotic prescribing in your facility. Many nursing homes run into the problem that they don't have control over their prescribers, though, and so they can't address the issues that are identified. It's definitely a challenge, but some of the strategies on this slide provide assistance with your prescribers. The first thing to do is to assure that nursing home leaders understand resistance patterns and antibiotic use in their facility. Once they understand that, they will be equipped to communicate with prescribers that antibiotics are not expected in their facility and that their prescribing rates will be monitored as part of the new CMS regulations. A facility policy requiring that cultures and antibiograms are used to guide treatment will also help to guide both prescribers and address problems with their prescribing with the weight of a policy behind it. These strategies aren't magic bullets, of course, but they can provide a good framework to begin working with prescribers on appropriate antibiotic use. So with all of that in mind, I'd like to bring us to some specific examples. How would you know a new administrator in a nursing home has made antibiotic stewardship, how would the new administrator, know whether the facility has made antibiotic stewardship a priority? Please put your answers in chat. We'll look those over and I'll give you a little bit to respond. Yeah, Dana has pointed out that talking to the infection preventionist is a great way to tell whether the facility is working on antibiotic stewardship. That's definitely true. A QAPI program, absolutely. Infections decreasing, yes. Oh, good, that's flying in now. QAPI is definitely a large factor. The other examples could be nursing staff having structured tools to document and report when a resident is suspected of infection. Laboratory or pharmacy could provide a report of antibiotic resistance in the facility. Yeah, there will be infection rate monitoring and review, absolutely. So, yeah, thank you for all your answers. I'm going to kind of flip it here and say, what about the reverse? How would the facility staff and providers know whether a new administrator is committed to antibiotic stewardship? Please go ahead and put those answers in chat as well. Yeah, Michelle says they'll get education from an infection control nurse. Absolutely. The administrator would see policy and procedures in the facility. The administrator would enforce and give education. Absolutely. Opportunities for education are a huge way an administrator can show commitment to antibiotic stewardship. Taking interest in QAPI and answering questions from staff. Absolutely. And asking questions related to the facility policies. Yeah, that could include questions like asking what the rate of antibiotic starts is, all of those data pieces we've already talked about. The other area an administrator could show commitment is requesting that the medical director provide feedback to their prescribing clinicians about their antibiotic use practices and host meetings with those who have unusually high prescribing rates. So, yeah, thank you for your responses, everyone. Those are, great and concrete points that can show commitment to antibiotic stewardship in a facility. So we're just moving right along today. So we'll just go ahead and wrap up our time with some major take-home messages. The first is that antibiotic stewardship programs help reduce inappropriate antibiotic use, and that inappropriate use can cause adverse outcomes, including drug reactions, expensive resistant infections, and C. difficile. It's related to a lot of harm in skilled nursing facilities. Evidence-based strategies can be used to be good stewards of antibiotics and protect your residents. I really hope that you learned some useful strategies today to start implementation in your facility and expand as you're prepared. And finally, teamwork is really required to support appropriate antibiotic use. Everyone in the facility has a role to play, including leaders, prescribers, clinicians, staff, residents, and their families. Communicating expectations and policies and educating these groups can help spread compliance with the antibiotic stewardship program and take some of the work off of that IPCO. This slide contains several links that are to resources available for your use. So the handouts are available to you. Please take a look at them and use what's helpful as you develop your antibiotic stewardship program. Additionally, the Lake Superior QIN website has a sample nursing home antibiotic stewardship policy, which is a great place to start and adapt as you develop your own policies. So for more information about antibiotic use, antibiotic stewardship, Clostridium difficile, and team step communication strategies to promote quality and safety, you can access free online training sessions that have been developed by the Centers for Medicare and Medicaid Services using the link available on this slide. Nursing home leaders can review the content in each session and decide which components would be helpful for themselves and which to include in educating other staff. The components can be shared and discussed during staff education in-services or discussion sessions, or they can be included by accessed by staff online at any time. Sessions are designed to take 30 to 90 minutes per session, depending on the number of components reviewed and the time spent on discussions and activities. The online learning sessions also are approved to award nursing contact hours. So this webinar was designed to be an introduction to antibiotic stewardship. So please come back in a week to attend the final webinar in this series, Antibiotic Stewardship in Long-Term Care Facilities, Where Do We Start? Dr. Cernich is a very knowledgeable speaker who will provide steps your facility can take to build your own program. You must register for this webinar. That information can be found at the link on this slide, and all of the webinars will be recorded and posted on Lake Superior QIN YouTube channel if you aren't able to attend next week. So with that, we now have time for questions or comments. So operator, can you please remind participants how to get in the queue?
Absolutely. Thank you. We will now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There will be a slight delay before the first question is announced. If you are using a speakerphone, you may need to pick up the handset first. Once again, if you have a question, please press star, then 1 on your touch-tone phone. Waiting on standby for questions.
We do have a question in chat here that says, are you saying that we need to keep track of all staff infections? What about the privacy of our staff? I understand your concern. That is not my intent in saying that you should track infections. Policies in place that say, staff should not be at work with active infections are always great, and definitely policies to implement hand hygiene to prevent spreading infections, but I'm not saying that you need to know the individual health status of each of your staff.
And I'm not showing any further audio questions at this time.
Okay. I see one more question that says, is there a certain rate of antibiotic use daily therapy that you should be striving for? That's a great question, but I can't give you, a benchmark right now, especially since nursing homes are really on the front lines now of developing their antibiotic stewardship program. The best thing I can recommend is to begin to calculate your days of therapy and discuss with your QAPI team, with your leadership, what a reasonable reduction in days of therapy would be, and strive for that. We'll give it a little bit more time if you have any questions.
And I'm showing an audio question. If you can please state your name, your first and last name. Your line is open. Please go ahead. Please go ahead. Your line is open.
Hi, this is Tara, Cant, Caltech, and I'm just asking whether or not the presentations will be provided to the participants.
Hi, yes, the presentations are all being recorded and will be available on the Lake Superior QIN YouTube page in about 2 weeks.
And will the slides be sent to the participants via email or just on the website?
The slides are available on the website, and there is a link for those in chat.
Okay. And the link is, I'm not quite sure where the link is. I don't see it in the chat.
The link is at the very beginning of chat, but we'll also add it at the end.
Okay, great. Thank you.
Okay, I see that there's a question on how many hours per week do you think needs to be dedicated to the program for the infection preventionist? I think that varies depending on the size of your facility, and that would actually be something that would need to be discussed in your copy meeting and with the administrator. I know it varies from facility to facility, anywhere from 32 hours a week to full-time, but it is dependent on your facility and the copy committee.
Once again, if you have audio questions, please press star, then 1 on your touch-tone phone.
We do have a question in chat that says, what type of statement should be in a job description for various staff? Again, that will vary based on your facility, based on your policies, and based on what works. But for prescribers, it could be, we will commit to prescribing antibiotics only as needed. For nurses, it could be, we will commit to monitoring antibiotic use or assuring that there is a clinical indication for antibiotics. You know, for staff and families, I'm sorry, for residents and families, not that they have job descriptions, but you could encourage them to be active participants and ask whether an antibiotic is actually needed. There are a variety of ways that job descriptions can be included.
We have an audio question from Ms. Nola Smith. Please go ahead. Your line is open.
Well, it was just answered because that was me who typed in the question. I didn't think it had come up, so my question was answered. Thank you.
Thank you.
Once again, please press star, then 1 on your touch-tone phone. We have a question from Rob McCall. Please go ahead. Your line is open.
Hi. I just want to clarify how you said days of therapy. You had two example there. If you have one antibiotic for 7 days plus another antibiotic, it equals 14 days of therapy, so it's counting each individual antibiotic.
Yes, exactly. A day of therapy is one antibiotic for 1 day. So if there are 2 antibiotics given for 7 days each, then that would equal 14. Does that make sense?
Yeah. Just wanted to clarify.
Thank you.
Our next question comes from Heather Orlando. Please go ahead. Your line is open.
Hi there. I missed the very beginning, so this may have already been answered. But anti-infectives, do those count as antibiotic treatment, or if they're used long-term or short-term? How do you specify those on any type of reporting?
Could you clarify what you mean by anti-infectives?
Like macrobid, trimethylprim for chronic UTIs / new UTIs that are used short-term.
How do they clarify for antibiotic reporting? Was that the question? I'm sorry.
Yes.
I'm not sure I can answer that 100%. I think that might be a question for the pharmacist.
Or that's also a great question for Dr. Cernich next week.
Yeah.
Okay, I will ask it next week then. Thank you.
Thank you. We have a request in chat to go over the antibiotic timeout again. We can absolutely do that. That's a policy that's used in hospitals frequently. It is a policy designed basically after 48 hours of being on an antibiotic. The care team will take a minute, will take a break and stop and review if that antibiotic is still necessary. They can review the past 2 days and see if it's working. And if it's working, maybe they can choose a different antibiotic that's not as broad spectrum. Or after 2 days, if they're not seeing success, they can change the antibiotic, or they can take the patient off that antibiotic, maybe once lab reports are back or something. The timeout is really just a chance to review a prescription that was started and make sure that it's the most appropriate option.
We have a question from Ms. Heather Orlando. Please go ahead. Your line is open.
Hi there. What you just explained kind of brought a question to my mind. When we have urinary tract infections that are symptomatic, and we use in the GEARS list, when it comes to doing a UA and we send that in, we usually do not like to start treating with antibiotics until there is a culture and sensitivity that is returned. Some of our doctors in the past have wanted to start them on a broad spectrum right away, and then it has not been susceptible to the bacteria that's been cultured. So what is your recommendation? Is that another doctor question, or is that something you can answer?
Well, I can tell you from the hospital perspective and from the antibiotic stewardship perspective, what you do now, waiting for lab cultures, is fantastic. The antibiotic stewardship, or the antibiotic timeout, that's used in hospitals, is often because they just want to start an antibiotic because the patient is in such critical condition that they can't wait. So if you are able to wait for labs and sensitivity reports, that is the best thing to do.
Okay, so if we have a doctor that does not want to do that, but based on symptoms wants to treat, then is that something that we should then do as an antibiotic timeout after that 40 hours while we're waiting for that CNS to come back, up to 72 hours?
Yes, it's a great policy to just, if he's determined to start treatment, to once you get the sensitivity reports back or the lab results back, to review the antibiotic that the prescriber started and to make sure it's the most appropriate, or to change it if it's not.
Okay. And that's what we kind of do right now for those that don't want to wait. Our best practice would be to wait for that culture, though.
Yes, absolutely. That's great.
Okay. Thank you.
Our next question comes from Abby. Please go ahead. Your line is open.
Hi. I just have a question regarding antibiotics that are ordered and not necessarily given, like for dental work or, procedures or anything like that. Is that something you're only going to track if you're giving it, or is this not even included in the sample?
That is a great question. That can be tracked depending on which measure you're choosing to track. So, for example, if you're tracking antibiotic prescriptions, that will get picked up. But if you're tracking antibiotic utilization, that will not get picked up. So it really will depend on which measure you choose to use for your facility and what makes sense for you.
Once again, if you have a question, please press star, then 1 on your touch-tone phone.
We do have a question in chat, that says, does bacitracin ointment count as a standing house order? Does it count as needing to be tracked? That is also a great question for Dr. Cernich. I'm sorry we can't answer that here today, but he'll be able to help you with that.
We have an audio question from Charlie. Please go ahead. Your line is open.
Hi. My question is it true that the infection preventionists now have to be a certified RN?
I believe that they can also be, I believe from MedTech, or not a MedTech, excuse me. I don't have the proper answer to that right now, actually. I know they can be an RN or another physician, and I don't have that answer in front of me right now.
They can be an LPN?
That I think is facility dependent. I'm not 100% sure on that.
Somebody put that can be certified.
If you reach out to your state contact, we'll be able to look in the final rule and follow up with you on that.
Okay, thank you.
And I'm not showing any further audio questions at this time.
Thank you. Actually, on Charlie, I see that Diane Dome, your contact in Wisconsin, said that there is no requirement at this time that the IPCO must be certified. So, there we go. Thank you, Diane.
Thank you, Diane.
Okay, if there are no more audio questions, we're not seeing any more questions in chat, so we will go ahead and wrap up for today. If you have any further questions that come up later, or if you're interested in joining our CDIS field tracking initiative, please contact your state representative with the information listed on this slide, and they will be able to follow up with you.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating.